Okay, now let's move on to the final talk. The final speaker will be Dr. Gen Miura. He's an assistant professor of Chiba University of Ophthalmology, and he's going to talk about the electrophysiological evaluation of retinal ganglion cells in glaucoma.
Thank you very much for inviting us. I talk about electrophysiological evaluation of retinal ganglion cells in glaucoma. As you know, glaucoma is characterized by an apoptotic retinal ganglion cell death, whereas bipolar cells and photoreceptors remain nearly normal. The death of retinal ganglion cells during the progression of glaucoma results in visual field defects. Visual field testing is commonly used to evaluate visual function in patients with glaucoma. However, visual field test is a subjective test, so its result is not always correct. In addition, visual field test is not sufficient to detect nerve dysfunction in early stage glaucoma. Electroretinogram can evaluate the function of each layer of the retina and pathway objectively by analyzing waveform. For example, it is thought that A wave is generated from photoreceptors and B wave is from bipolar cells and oscillatory potentials is from amacrine cells. That's why ERG is used for pathology grasp and clinical diagnosis. There are several types of ERGs. Left side is the image of stimulus of full field ERGs, and right side is the stimuli of multifocal ERGs. By patient fixation to the center of the stimulus is projected onto the fundus. Yes. And in full field ERG, which is commonly used for clinical, the waveform is generated from whole retina. In contrast, multifocal ERG can be recorded from focal responses during a single recording session. Several attempts to assess retinal ganglion cell function was reported previously. Effective method to affect the effective method to evaluate the function of retinal ganglion cell is to measure the photopeak negative response. It is called PHNR, which is negative going wave that occurs after the B wave of the full field photopeak ERGs. Left figure shows the monkey's full field ERG of control eye and experiment glaucoma eyes by laser photocoagulations. And the right side is the waveform before and after intravitreal injection of tetrodotoxin, which blocks third order neurons. Since PHNR is generated mainly from retinal ganglion cells, PHNR is markedly reduced in experimental glaucoma and after TDX injection. But PHNR cannot monitor the local changes of retinal ganglion cells. In contrast, multifocal ERG can be recorded from focal response, and number and color and positions of a stimuli can be changed as you like. The first negative wave is named N1 and next positive wave called P1, and second negative wave after P1 is N2. Several studies about the multifocal ERGs in glaucomatous eyes have been reported. Please let me show some of the studies about that. Dr. Hood found the P1 plus 8.3 millisecond amplitude become smaller in glaucomatous eyes with fast frequency multifocal ERG. But there was no correlation between visual field defect and the amplitude. Dr. Margarita reported that the latency of the N2 on response was significantly delayed in glaucomatous eyes with long duration flashes. Other researchers reported about S-wave, which is a small positive wave that is present on the descending limb of P1 when the multifocal ERG is recorded by 75 Hz frequency. They reported that the significant correlation between the S-wave amplitude, the mean deviation of Humphrey field analyzer, and the retinal nerve fiber layer thickness. These results suggest that the S-wave is related to the neural activity of retinal ganglion cells or their axons. However, correlations of not each local, but average of whole response were investigated despite using multifocal ERGs in these papers. Dr. Satomi and Dr. Okano have analyzed Humphrey field analyzer data from glaucomatous eyes separately for upper and lower visual field halves and analyzed the relationship between the mean deviation and the P1 and N2 amplitude in the multifocal ERG in the corresponding visual field. They found that the correlation between the mean deviation and the P1 and N1 amplitude were not significant. Dr. Palmowski divided the visual field of each glaucomatous eye into 4 segments and analyzed the relationship between the mean deviation and the N1, P1, and N2 amplitude of the multifocal ERG for each segment. He found no significant correlation between the mean deviation and the amplitude of those waves in the multifocal ERGs. It was reported that the biphasic responses of the multifocal ERG appear to be generated by the same cells generating the A-wave and positive peaks of the full-field cone ERG. This means that each waveforms of multifocal ERG and full-field cone ERG has similar origins. That's why we assume that N2 wave of slow sequence multifocal ERG may have similar origin to PHNR of full-field ERG. Next, please let me introduce our recent study about multifocal ERG and glaucoma. The purpose of this study was to determine whether the N2 response of the multifocal ERGs can evaluate local retinal ganglion cells function as well as the PHNR of the full-field ERG. To accomplish this, we investigated the correlation between the N2 of the multifocal ERGs, retinal sensitivity, and RNFL thickness in glaucomatous eyes. "38 eyes of glaucoma patients and 11 eyes of normal volunteers were included in our study. There are no significant differences with the ages of both groups. The average of mean deviation of Humphrey field analyzer 32 was minus 9.4 decibel, not so severe glaucoma. Only patients who diagnosed with primary open-angle glaucoma or normal attenuation glaucoma were included. Secondary glaucoma, cataracts, retinal disease, or previous ophthalmic surgeries were excluded. We use red stimuli on the blue background, which can saturate the ROT pathway. 9.4 Hz frequency we use. This is slow. Usually 75 Hz is used for clinical. Response from central 5 elements within 20 degrees were analyzed. Each two responses in the superior and inferior elements were summed. Mean and amplitude were analyzed. Superior and inferior retinal sensitivity was determined by Humphrey 32 inside red lines. Central retinal sensitivity was determined by Humphrey 10.2. Since the decibel value is from logarithmic scale, so retinal sensitivity converted from a log value to a linear value using numerical formula below. The spectral domain OCT was used to measure the RNF thickness from inner limiting membrane to the outer of the ganglion cells layer. Superior temporal sector corresponds to the inferior retina, and inferior temporal corresponds to the superior retina. And the average of temporal upper and temporal lower correspond to the central retina. And Dr. Galloway previously reported about this correlation. Let's see the two cases. Upper side is ERG and RF thickness and retinal sensitivity of normal volunteers, and lower is those of glaucoma patients. There is a visual field defect on the upper side of the macula, and N2 amplitude and RF thickness decreased in corresponding areas. Let's see result. We compare the N2 amplitude. N2 amplitude were significantly decreased compared to normal groups in all three retinal areas. This is comparison between N2 amplitude and retinal sensitivity. A significant correlation showed in all three retinal areas in both groups. This is comparison between N2 amplitude and RF thickness. Significant correlation was shown in three retinal areas. This is summary of our result. N2 amplitude is significantly decreased, and significant correlation shown in both retinal sensitivity and RF thickness. This is our conclusion. The N2 amplitude was significantly correlated with both the retinal sensitivity and RF thickness. The result indicates that the changes in the N2 amplitude are due to the dysfunction of the retinal ganglion cells. Examination of the N2 amplitude may be a useful method to diagnose and follow the course of glaucoma objectively. Thank you very much for listening.
Thank you very much. So, is there any question or comments? Okay, so I'd like to conclude this session, and I'd like to thank you for all of your attendance. Thank you very much.